All right, guys, welcome back. So, if we're going to talk about your respiratory system and that gas exchange, that really starts with this process of breathing. And so, we need to be able to get air into your lungs and air back out. So, let's sort of pick up today and just follow that path of air initially. And so, when you take a breath in, most people will breathe typically through your nostrils as a just sort of normal everyday breathing cycle. So we're going to enter that air in through these external nares. That's going to end up coming through and following along these nasal conchi. All right. And then down into your internal nares. So if we're breathing through our nose, we're going to follow this path here. As that air comes down, it's going to end up being in the back of your throat, passing through that pharynx, and then ultimately going across that esophagus and down into your larynx first. If we keep following that larynx then empties down into your trachea, and those trachea then start branching off, and they'll branch into your right and left primary bronchi. Those will then branch off into secondary bronchi, tertiary bronchi, until we finally get to those terminal bronchioles, which are the smallest branches that are then directly connected to these respiratory bronchioles that empty out into your alveolar ducts, and then ultimately into those alveolar sacs and into those individual alveoli themselves. And that's where that gas exchange can happen, because now we're very thin walled structures, and the capillaries are right there as well. Okay. But if we take a step back and talk about the breathing process itself, so how do we actually ventilate the lungs? How do we get air in and air out? And really, that breathing is just an alternation between inhalation, so bringing air in, and exhalation, bringing the air back out. And interestingly enough, there are some different mechanisms for how organisms take care of that breathing process beyond just the actual structure of the lung itself. The way that they use those lungs is also a little different. So when we talk about mammals like us, our ventilation system works by a negative pressure breathing system, in which what we're looking at is a pressure differential from what we're talking about in terms of pressure inside your lungs as opposed to what's outside your body. And that negative pressure breathing means that there's less pressure in your lungs as you breathe in. So just like diffusion and just like across a concentration gradient, it's the same concept, but now we're talking pressures instead. So we're going to go from high air pressure outside your body to low air pressure inside your lungs. And so the air essentially kind of just falls in there as a result of that pressure difference. Now, your lung volume has to increase in order to make this work. So if you stop yourself right now, take a really big breath, the biggest breath you've ever taken, all right, and pay attention to the way that you're doing it. How many of you actually took a deep breath, scrunched up your shoulders up to your neck, and sort of sucked your belly in? Somewhere along the way, a lot of people learn to take that deep breath, and it's backwards. So in order for this to work, we need to expand your rib cage as much as possible. Pull in and open up as much space as physically possible. And if you talk to people who are singers or things like that, they have sort of reversed that inaccurate learning somewhere along the way and learned to drop their diaphragm and expand their chest wall, just like you're supposed to do. And what that ends up doing is expanding all of that space so that we can actually allow that volume to open as much as possible. So if we want to look at how much air you are actually able to take in a given breath, we can talk about your tidal volume. All right, and that tidal volume, the maximum tidal volume, the maximum volume that you're capable of inhaling with each breath, given your lung capacity and things like that, is your vital capacity. The residual volume is how much air is actually left in your lungs when you exhale out. You're never going to get all of it back out. All right, there's no way to do that. So what do you end up with that's left? And those values can be important diagnostic tools. We look at other organisms, and I mentioned there's other ways to do it. So humans do it by this negative pressure breathing. If I look at something like the amphibians, theirs is actually the opposite. And so they do positive pressure breathing, in which case their pressure is actually higher in their lungs than on the outside. And so it's going to actually force the air down the trachea, and they've got to manage to take care of that. And so they drop their mouth, open up that cavity, and do it a little bit differently than we do. If we look at birds, they actually have an interesting lung setup. So as opposed to sort of breathing through their skin or breathing through gills, or breathing through our traditional lung structure that we think about in us, they've actually got these posterior, anterior air sacs as well as sort of a traditional lung structure. And so they have these things called air sacs or parabronchi. There's actually usually 8 to 9 in total, and they act like billows. So if you've ever taken old school billow to stoke a fire, it's this big air sac, and you pump it up and down. That's sort of what these air sacs are doing. They're puffing up and then squeezing air out, and that air then all passes through their lungs in a single direction, as opposed to going in and then back out in the same orientation. So it kind of almost looks like a circuit, like we would have seen with your circulatory system. So every exhalation completely renews the air in the lungs, as opposed to some of that air getting trapped like it would in ours. So what's this relationship, right? If we go back to what our body is doing, we're talking this pulmonary ventilation, mechanical process, right? Expanding the chest wall, moving the diaphragm, to create volume changes in that thoracic cavity. And those volume changes are what's creating the pressure change. And then that pressure change is what allows the gases to either fill or be removed as your body is attempting to equalize pressure inside your body compared to outside in its environment. So as the volume increases, your pressure drops. So that's what's happening when you're inhaling, right? Take a nice deep breath, open up your chest cavity, drop your diaphragm, open up that volume in your chest cavity as much as possible. That's going to cause the pressure to decrease. Air is going to flow into your body to equalize the pressure. When you exhale, now you're pushing up the diaphragm, collapsing the chest wall, decreasing the volume. Now your pressure goes up, air comes back out. So as a result of that volume and pressure change, we look at your lungs' ability to do its job appropriately in managing that volume and managing that pressure in terms of compliance and recoil. So compliance is simply how easy is it for your lungs to expand. All right, so what's the ability to distend that lung tissue, separate it out, make it bigger? And as a result, all of that's going to help to increase the surface tension in your alveoli, and so more efficiently move those gases, into your circulation. The recoil then is your lungs returning to their smallest size possible, and your body has to, or is set up, I should say, to ensure that there's enough compliance and recoil to effectively breathe without going too far in one direction. So you really have these two forces that are acting on the pulling of your lungs. So we look at your lungs sort of pulling away from your thoracic wall, which promotes lung collapse. So there needs to be that elasticity in your lung tissue to cause them to assume the smallest possible size. Think of it like a rubber band. You can stretch them, but you let it recoil back into its smallest size that it's capable of. Your surface tension in your alveoli, based on that surfactant that they're making, also will pull your alveoli back to the smallest possible size. That's a good thing to a point. All right, we also have to have forces that prevent that lung collapse. Otherwise, your lungs literally do collapse on themselves, and they don't work. So you've got forces that oppose that lung collapse by that lung tissue being attached to pleural membranes that are then attached to your body wall. All right, so there should be layers of attachment here that prevent them from going all the way back down to their smallest size possible. And then there's also elasticity to the chest wall itself that allows you to pull outward and expand those lungs as well. Okay, so here's the thing. We're looking at this compliance and recoil, and I need them both to be there and function appropriately. There are factors that are going to diminish your ability to allow that compliance to happen. So things like scar tissue as a result of just natural using of your lungs. Or we can increase that scar tissue because of disease processes or smoking. Any sort of blockages to those small respiratory passages, reduction of that surfactant by those alveoli, any sort of decreased flexibility to your thoracic cavity or its ability to expand, just general deformities. You can get ossification, so sort of almost turning this cartilage that's here connecting your actual rib bones to your sternum can ossify or become bone-like. And make this whole cavity rigid as opposed to being flexible. You can also get paralysis of these intercostal muscles, so these muscles that sit between your ribs here, can also get paralyzed, and as a result, sort of prevent the lungs from having that compliance as they should, that expansion that they need in order to get that air pressure to drop and be able to get the air to flow in, right? So what you're really doing is a constant give and take between your intrapulmonary pressure and your intrapleural pressure. So when we look at your lungs here, okay, we talk about your pleural cavity, right? So this is the cavity that your lungs sit in. And there's pleural pressure between the actual lungs itself and this space, okay? And just like your heart's in a pericardial sac, your lungs are also in pulmonary or pleural sacs as well that have mucus and surfactant to reduce the friction as those lungs blow up and collapse. So I have pressure in here on the actual lung tissue itself, and I've got pressure in here in that sac. And the idea here is that intrapulmonary pressure should always equalize itself with the atmospheric pressure. So the pressure in here is trying to equalize the pressure outside your body. Okay, and that's why air goes in or air goes out based on that pressure differential. I also need to ensure that my pressure, intrapleural pressure, is less than your intrapulmonary pressure. Okay, and that's going to ensure that these guys are not allowing your lungs to completely collapse. I break these pressures because of some sort of malformation or injury, and we actually can get this pleural cavity to detach from the thoracic wall. Your lung collapses. You're not able to pull in oxygen and remove carbon dioxide effectively. And that's where we may talk about things like them needing to go back in and re-inflate your lungs, put a chest tube in there until your body can kind of heal and allow that to go back to normal. So here's sort of just that sequence of events, moving those muscles, increasing your lung capacity, increasing the volume, changing the pressure so that the gases can actually go in. And then how does that happen as we move all of this material back in, decreasing the volume, allowing the pressure to go up, and as a result, the oxygen to go back out. Or excuse me, the carbon dioxide to go back out, the air to go back out.